RotexTable attachment is an electronically operated system that allows us to perform anterior total hip arthroplasty. So as the demand for elective joint replacement increases with time, the key factors to success for arthroplasty surgeons will be to maintain efficiency and to cut down on cost. And the RotexTable allows us to really do both. It's allowed me to become less reliant on circulators and scrub techs to help maneuver the anterior hip table, and I can do it most of the case by myself with one assistant. When it's not in use, it takes up a much smaller space at the surgery center, and it allows us to utilize that space for other purposes. As an arthroplasty surgeon, we're sort of limited to doing the surgery either on a standard operating room table or to use a specific table designed for anterior hip replacements. This table is less expensive, it's more ergonomic to use, it has a smaller footprint, and those are really the reasons why I adopted it in my practice as a way to streamline doing these cases on a more cost-effective basis. The RotexTable can be attached to your current operating table. The carbon fiber adapter is secured into place. Next, the leg board is attached, followed by the Rotex arm. The footprint of the Rotex attachment, when not in use, is similar to that of an IV pole. Once spinal anesthesia has been completed, a boot is placed on the operative leg. The patient is then pulled down into position after the Rotex arm has been attached. The central post is placed to secure the patient. The surgeon controls rotation of the leg using the rotator switch. When the switch is up, internal rotation is locked. When the switch is down, external rotation is locked. When the switch is in neutral, rotation is unlocked. Traction of the leg is controlled by the red ball switch. The surgeon or assistant pulls on the leg and the red ball is pushed down, locking the traction. To release traction, the red ball is pulled up. Extension of the leg is controlled by the foot pedal. The base of the Rotex is unlocked and moves passively to prevent tension on the extremity. As a safeguard to prevent traction injury, extension of the limb cannot occur unless gross traction is released. Draping is performed to allow access to the necessary switches of the RotexTable. Surgery is then performed in standard fashion. Traction is placed on the leg for ease of femoral head removal and acetabular preparation. Once the acetabular component is placed, femoral exposure is undertaken. Gross traction is released on the extremity. The leg is locked in external rotation. Standard soft tissue releases are performed on the femur. The surgeon uses the foot pedal to place the leg in extension. The Rotex tower is pushed over to allow for hip adduction. Femoral preparation is performed without the need for a femoral hook. The hip is then brought out of extension and adduction. The surgeon is able to reduce the hip with gentle traction and internal rotation. Anterior hip stability is tested in extension and external rotation. The foot can be taken out of the foot holder to test posterior stability. At the conclusion of the case, the foot is removed from the leg holder, the Rotex arm is disengaged from the table, and the leg board is attached.